and stuff. So we've never had to deal with a real large-scale successful biological attack, and I hope we never will. I hope these 2 hours are a total waste of your time, and I hope the last 20 years of my career were a total waste of my life. But anyway, this is how I envision we might have to deal with this if it should ever happen. So the first, and I've kind of stylized this as the 10 Commandments. So it's a 10-step approach that I think will serve us well if we ever have to deal with a biological attack. But I also think it will serve us well if we have to deal with a chemical attack and a lot of other things. Because I don't want you to have a whole separate paradigm in your mind for dealing with a biological attack. I want you to kind of respond the way you would respond normally to anything else. So I've tried to meld this into more conventional guidelines, and we'll talk about that. But the first thing I think we're going to need to do is we're going to need to maintain an index of suspicion, because if it isn't tucked away somewhere in the back of your mind that there are bad guys out there, and there are nutcases out there, and they're going to do weird things once in a while, then you're not going to be very likely to arrive at a correct diagnosis very quickly. Now, 15 or 20 years ago, I think this would have been a tough sell to try to convince you to walk around thinking about biological terrorism. But now, in the aftermath of 9/11 and the anthrax attacks and a lot of other terrorist actions, I think this is a no-brainer. I think all of us know now that there are weirdos out there, and they're likely to use these agents if they get the chance and if they can get their hands on them. Now, again, I'm a biological kind of person. I'm an infectious disease doc. I spent a good chunk of my career at USAMRIID, but I would argue that everything we're going to talk about here today applies equally well to chemical warfare and chemical terrorism as well. But maintaining that index of suspicion in the face of a chemical attack, I would argue, is a no-brainer, because chemical agents don't have the incubation periods that biological agents do. So when a chemical agent goes off, everybody falls down immediately. And consequently, the casualties are likely to be very tightly clustered in time and space. So when I was on active duty and I was teaching young medics on the battlefield, I'd say, look, you're bopping along the battlefield and you come across a bunch of soldiers and they're laying on the ground, and you turn them over and there ain't no bullet hole in the center of their chest and there's no shrapnel wounds. Well, they must be the victims of a chemical attack, because there's not much else that causes casualties to be tightly clustered in time and space. And in fact, it's easy to confirm that suspicion. So I'm going to lapse into some military talk here just to make a few points. But this is kind of the military's chemistry set. And there are civilian versions of this now. And so big city emergency rooms and some ambulance squads have kind of similar capability. But this is the M256 kit. It's 1970s era technology, and it's designed to be Snuffy-proof. So Private Snuffy is our mythical 18-year-old kid. I say that with all due affection. So Private Snuffy is our 18-year-old kid who's an infantryman. His job is to crawl through the mud for his country. He is not a PhD chemist. He's not board certified in infectious diseases. He's not a toxicologist. He's a kid whose job it is to shoot bad guys. But he is taught that if he suspects there's a chemical agent out there, he can whip out this handy-dandy little chemistry set, do a few quick and dirty tests, and very quickly confirm or refute the presence of a chemical agent. So, bottom line is, it's easy to suspect a chemical agent, and it's relatively easy to confirm that. And to summarize, when a chemical device goes off, everybody falls down, the casualties are tightly clustered in time and space, and consequently, the first responder to a chemical attack is likely to be the traditional first responder. It's likely to be the fireman, the policeman, the paramedic, etc. On the other hand, a biological agent goes off, the device goes off, and assuming the bad guy doesn't do us the favor of telling us, and half the time they do, but assuming they don't tell us that they released it, no one's even going to realize it. And remember, biological agents have an important characteristic that chemical conventional nuclear agents don't have, and that's an incubation period. That incubation period is usually several days in duration. So these casualties who aren't sick yet, they're going to get on planes and trains and automobiles, and they're going to scatter to the four winds. They're going to be widely dispersed in time and space. And when they do get sick several days after exposure, what are they going to do? Well, most of the time they're going to seek medical attention. And so the first responder to a biological attack is far more likely to be the medical and the public health people. And that's why we focus a lot more in public health and preparedness communities on biological attacks. Now, I would argue that even in the case of biological warfare, it's easy to maintain an index of suspicion if you see these diseases in their full-blown form. And that's because most of them, at least the big four, these are what I would consider kind of the big four of biological terrorism. These have characteristic hallmark diagnostic associations. So, for example, anthrax, the characteristic finding is a widened mediastinum. So for those of you who are not medical, the mediastinum is the center of the chest. It's where the great blood vessels and a few lymph nodes, the space between the lungs and stuff. And anthrax causes disease of the mediastinum. And the good news is there aren't many other diseases that do that. Certain rare cancers can do that. Obviously, a gunshot through the center of the chest can cause your mediastinum to bleed and swell. But the bottom line is there aren't too many diseases that do that. So if you have a widened mediastinum, and the only way you're going to know that, obviously, is to get a chest x-ray. And I understand you're not always in the position to get a chest x-ray. But if you do and you see a widened mediastinum and you roll the patient over and there's no bullet hole through the center of their chest and they're not impaled on their steering wheel, then they must have anthrax. There's not much else that looks like that. Plague causes hemoptysis. It causes the coughing up of blood. Now, can other diseases cause you to cough up blood? Of course. Staphylococcal pneumonia can do that. Klebsiella pneumonia in elderly alcoholic patients can do that. Pulmonary tuberculosis can do that. And of course, a gunshot through the lungs can do that. So if I have a single patient in my emergency room coughing up blood, I need to run through that differential diagnosis in my mind. I need to sit there and say, could it be staph? Could it be Klebsiella? Could it be tuberculosis? Do I need to put a skin test on them? Blah, 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 blah. On the other hand, if I have 5 previously healthy young people in my emergency room on the same day and they're all coughing up blood, I promise you they didn't all reactivate their pulmonary tuberculosis at the same time. So when I see multiple patients like that, there's not much else that can be. That diagnosis ought to be a no-brainer. Smallpox has a very characteristic viral exanthem, very characteristic rash. So none of us have ever seen a case of smallpox. It's been gone from the United States since the 1930s. And so the first time you ever see a case, yeah, maybe you won't know what it is. Maybe you will confuse it with chicken pox. But it is so characteristic in its appearance that the second time you see a case, you'll never forget it. Botulism causes a flaccid paralysis. Can other diseases cause flaccid paralysis? Yes, the Guillain-Barré syndrome can do that. Myasthenia gravis can do that. A few other rare neurologic diseases can do that. So if I have a single patient with flaccid limb paralysis, then I need to, again, run through that differential, perform some tests, et cetera, et cetera. On the other hand, if I have 5 previously healthy Honolulans in my emergency room, is that the right word, on the same day, I promise you they all didn't get Guillain-Barré syndrome on the same day. So multiple patients with flaccid paralysis, not much else that can be. So you've now had 1 hour of training on biodefense and about 30 seconds on this disease. So what is this? Is a wide mediastinum, the center of the chest. So this is anthrax, right? If I told you this young lady's coughing up blood, she has plague. This baby has, and as a pediatrician, I can tell you all teenagers look like this. But if I told you this kid's so weak that he can't even smile, he can't lift his eyelids, he has botulism. And see, it really is that easy. So I assume most of you have probably never seen a case of any of these 4 rare diseases, and you've had at most 1 hour of training, and yet one quick look at the picture and you all got the correct diagnosis. So these diseases really are that easy to diagnose if you have that index of suspicion and if you see these diseases in their full-blown form. The problem, though, is not every disease is that easy. So tularemia, even in its full-blown form, looks like little more than fever and I don't feel good. Brucellosis is fever and I don't feel good. Q fever is fever and I don't feel good. Venezuelan equine encephalitis is fever and I don't feel good and I have a bad headache. But more ominously for us, prodromal plague, early anthrax, early smallpox are often little more than fever and I don't feel good. So that patient, that gentleman with the widened mediastinum that I showed you, what's his prognosis? Yeah, not very good. So he probably has 95% mortality rate at that point. So of course we're going to pull out all the stops. We're going to try to save his life. But our goal is really not so much to save his life. Yes, we want to do that. But our goal really is to learn from him. He's the canary, and it's to learn and say, wow, that guy has a wide mediastinum. I flipped him over. I didn't see any bullet holes in the center of his chest. He's not impaled on the steering wheel of his taxi. He must have anthrax. And he may be a goner, but if I can, but if he got exposed to anthrax, maybe a lot of other people did. And if I can get out and get to them before they get to this point of having a widened mediastinum, then maybe I can do a little bit of good. But unfortunately, again, early anthrax looks like little more than fever, and I don't feel good. And that's where the problem lies for us. So once in a while, we may be able to use epidemiologic clues to help us maintain that index of suspicion. So I think most of you know that even during a bad flu season, even on your worst night in a busy emergency room, you're unlikely to see more than a small handful of cases of true influenza. So if you see more than that, then that ought to raise a red flag in your mind that maybe I'm dealing with something sinister. If you have unusual geography, so if it dawns on you, and I don't know how it would ever dawn on you, but if it dawns on you that the patient standing in front of you has Venezuelan equine encephalitis and you ain't in Venezuela, then that ought to tip you off. Localized geography, so if everybody living on the hilltop is fine, everybody living in the valley is sick, that ought to tip you off. And you can read the rest of this list as well as I can. In the military, in the chemical world, we have these standoff detectors. So again, this is 1970s era technology. This is nothing high-tech, but these are alarms that were designed for a battalion commander to position around his perimeter. And if a chemical agent, nerve agent, was in the area, then this alarm would go off and his soldiers would have about 9 seconds to get into a gas mask. Now, that works okay, I guess, if you're within 9 seconds of a gas mask, and trained soldiers are often. But obviously it's a non-starter in the civilian counterterrorism world. But I show you this just to make the point that it's theoretically possible to do standoff detection. In the biological warfare business, we're also working on that. So this is a portal shield device. It's about the size of a breadbasket or a microwave oven. And it's designed to suck in air, concentrate it down, and assay it for the presence of biological agents. Unfortunately, when you add the HVAC systems necessary to support it, it becomes a lot bigger. So this is a real portal shield device, really deployed on Pennsylvania Avenue near the White House in 1998 during the NATO 50th anniversary summit meeting. So the world's leaders were gathered in downtown Washington, and to protect them against a biological attack, we deployed 7 of these very inconspicuous devices around the White House. And the point is, you can do this. I mean, so for things you know that are going to be high-profile special security issues, like the Republican and Democratic national conventions, the Pope's visit, the Super Bowl, big NATO meeting, et cetera, you can position these detection devices around your perimeter. I think you can also see, though, that no public health official in the field is probably going to hump that thing out on a case investigation and stuff. So, although with computing power doubling every 18 months and the explosion in nanotechnology, I have no doubt that someday this thing will fit on your belt and you'll be able to not have to have an index of suspicion anymore because some machine will do that for you. But for now, I think you're stuck. If you're going to sell something in the Army, it has to look like a tree. So this is the biological integrated detection system. It's kind of the same thing. It drives around, sucks in air, concentrates it down, looks for the presence of weapons. This is the system you're more likely to encounter, though. This is the BioWatch system. And so there are 3,000 Environmental Protection Agency sensors scattered around the United States, including many here in Hawaii. So when you hear on the news that that it's smoggy in Los Angeles or the air quality sucks in Cleveland, it's because one of these EPA devices told you that, or told the weather people that. Well, we've retrofitted 600 of those with biological detectors, and so they will pick up the presence of anthrax and stuff in the air. The problem is they're not truly standoff yet, because somebody has to go up to them every day, physically take out the filter paper, take it to the laboratory and assay it. But it's a big step forward from where we were 20 or 30 years ago. So the point is, standoff detection is coming, but for now, it's up to you to maintain that index of suspicion. So we're through one of the 10 commandments and only 25 minutes into the talk, so I should finish by about 4:30, 5 o'clock with this stuff. So you have your index of suspicion. Now, the next thing you want to do is you need to take steps to protect yourself, because obviously if you become a casualty, you're of little use to your patients. So when we talk about, and let me just say, this talk is a 45-minute talk. It's not designed to be the be-all and end-all. We can't possibly, we could spend hours on every one of these subtopics, and I would have if they would let me, but so we're not going to do that. And what I rather want to do is to demystify, to hit some of the controversial points and to demystify some of the bad information out there. But when we talk about self-protection, we can talk about physical protection, we can talk about chemical protection, and we can talk about immunologic protection. And again, we're just going to hit the high points here. So when we talk about physical protection in the military, that means MOP gear. That's the whole suit with the gas mask and everything else. And we'll talk about that in a second. It can also mean Serpaqua, which I forget what that is. Something protection against chemical warfare agents. So it's like suntan lotion. You put it on, and it inactivates certain chemical agents on contact. And obviously, in certain circumstances, we might be able to avail ourselves of some of those strategies. But I think you can also see that the opportunities to use something like that are probably going to be few and far between. It's possible to employ chemical prophylaxis. So, for example, if an agent from the Honolulu field office of the FBI came here today and said, look, dear people of Hawaii, we have credible evidence that Hezbollah is operating in Honolulu. They're armed with tularemia and they're prepared to use it. Then I guess we can all start ourselves on doxycycline. But I think you can see that the opportunities to employ a strategy like that are likely to be few and far between as well. And then sometimes we can potentially use immunologic protection. So if there were an anthrax attack imminent or a smallpox attack imminent, or if one had already happened, we could theoretically get ourselves immunized. So there are certain circumstances in which multiple of these might apply. There are other circumstances in which none of them might apply, but at least you need to consider that before you start seeing patients. So I want to, again, hit some of the high points and demystify certain things. So this is the military's answer to physical protection. So when Uncle Sam designed this MOP gear, when he contracted for it, he said, look, contractors, design me something that will protect my soldiers against nerve agent, against a chemical agent. And this is what we got. And it does that very well. So this protects against nerve agent. Will it protect against biological agents? Of course, because if this will filter out tiny little chemical molecules, of course it'll filter out much bigger bacteria and viruses. But I think you can guess that it's also very mission degrading. So I spent a good chunk of my career in Texas, and when we trained, we went to a place called Camp Bullis, north of San Antonio. At Camp Bullis in July, it's 104 degrees. At Camp Bullis in July, in this rubber suit, it's 154 degrees. So I can stay in this suit for about 20 minutes before I'm pouring the sweat out of my boots. Now, if there's nerve agent in the atmosphere, I'll suffer, and I'll stay in that suit. On the other hand, if there's not nerve agent, if there's not chemical agents there, and all I'm worried about is biological agents, then that's overkill, and I want to get out of that as soon as I can. I'm a pediatrician, so this is actually Hawaii history here. So, so in 1942, around the same time they were contracting for these suits for adults, they awarded a contract to Walt Disney to design childhood MOP gear. And it was distributed on Oahu only in 1942 in the wake of the Pearl Harbor attacks. And so apparently there's a society of people who collect gas masks, and these are supposedly, there's always like 6 known to still exist. So they're very valuable on eBay if you have a pediatric MOP gear. But anyway, if I don't need to be, if I can rule out chemical agents and all I'm worried about is biological agents, then I obviously don't need a charcoal impregnated suit with a rubber gas mask. And in fact, I can rule out chemical agents, as we kind of alluded to earlier. And this is military technology, but there are definitely civilian versions. So on the left there, that's the chemical agent monitor. It's ugly green if you sell it to the Army. The ones that they sell to the civilian world are yellow, but they have them in big city emergency rooms. They have them in certain squads and ambulances and stuff, and this litmus paper-like stuff, same thing. So this stuff is out there, and it's a way to easily confirm or refute a suspicion of chemical agents. So if I can rule out chemical agents and all I'm worried about is a biological agent, then I don't want to be in that heavy suit. Now, this is a T-shirt under a microscope, and you can see that one of these army t-shirts, they don't have a very tight fabric weave. You can see there's big holes between the threads. So a t-shirt held over your mouth and nose probably is not an acceptable substitute for a gas mask, right? Except we did that study. So if you focus on the lower part of this slide, we took, at USAMRIID, we took rats, and we exposed them to saxitoxin, which is a low molecular weight toxin, and all of the rats dutifully died for their country. And then we took a t-shirt and we folded it over on itself, and we held it over the snout of the rat, and we exposed them to saxitoxin, and they all survived. So a t-shirt folded over on itself actually did protect you against saxitoxin. If it will protect you against a small molecular weight toxin like that, it will also protect you against bigger things like viruses and bacteria. Now, why do I tell you that? Do I tell you that because I think you can just, don't have to worry about anything, just hold a t-shirt over your mouth and nose? No, although that's what I would do if I was caught otherwise unprepared. But the real reason I tell you this is because what is a t-shirt? Really, it's the field expedient version of something we use in clinical medicine every day, the simple surgical mask. And so if a surgical mask will protect you against conventional bacteria and viruses, it will also protect you against most of these agents, because the dirty little secret is a lot of these viruses don't know how much they scare us. They think they're just viruses, just like everything else. All right, so why do I tell you that a simple surgical mask is good enough for you, but this is what we used to do at USAMRIID? Because we have it and you don't. So no. So this is the aeromedical isolation team. So this is BSL-4 level technology. But I would postulate that all the diseases we're talking about today are actually BSL-3 pathogens. So anthrax and plague and tularemia, those are all BSL-3 pathogens. So even at USAMRIID, where we had that technology, we wouldn't have used it. This is the entire list of BSL-4 pathogens, so we probably would have used it for Ebola, and variola, that's smallpox. We probably would use it for smallpox. So let's say you had and that team doesn't exist anymore. It was decommissioned in 2012. But back when, so it's a moot point anyway, but back when we had it, let's pretend you had a smallpox patient. What would you could call us, and we would love to come and get that smallpox patient, because we had 16 young medics who trained, and they wore these suits all the time. They did all this training and practice, and they never got to do it for real. So they would eat that shit up if you had a smallpox patient. They would love to come and get your patient. Now, what would they do with the patient? Well, they'd take them back to USAMRIID, because we had the nation's only BSL-4 hospital, and that hospital was 2 beds. So if you had 1 smallpox victim, we were there for you. If you had 2, we were there for you. If you had 3, you're on your own. So the bottom line is that this technology is not necessary, and it's not available. And I show you that again just to demystify this, because I think there's a lot of bad information out there that would say, if you don't have this kind of technology available, you can't do biodefense correctly, and nothing could be further from the truth. All right, so you got your index of suspicion, you've taken a step to protect yourself. Now it's time to start seeing patients. And when we see patients in a conventional setting, we see them one-on-one. We see a patient, we take a history, do a physical, we may order some lab tests, get some x-rays, talk to the family, make a diagnosis, prescribe some therapy, and we do all that before we move on to the next patient. But in a mass casualty incident, we do things a little bit differently. Now we invoke the notion of triage, and triage involves a primary survey. And when we do the primary survey, our goal is not to make a brilliant diagnosis of ulceroglandular tularemia. Our goal is save the patient's life. So how do we save the patient's life? Well, the same way we do in conventional medicine. First thing we do is we secure the airway. That's important for conventional reasons, but also because mustard and lewisite and phosgene, which are all chemical agents, not biological agents, but if they're going to produce casualties, they're usually going to produce casualties in the upper airway. And then we want to make sure the patient's breathing okay. We want to do that for conventional reasons, but also because anthrax and plague and tularemia and botulism and staph enterotoxin B and Q fever and ricin and a lot of other things, if they're going to produce casualties, they're going to produce pulmonary casualties. And then we want to turn ourselves to the circulation, make sure the patient's circulating okay. Again, we want to do that for conventional reasons, but also because plague and the viral hemorrhagic fevers and cyanide intoxication can cause circulatory collapse. And then the D in the ATLS paradigm usually means disability. That implies neuromuscular disability, and that's important too, because some of these diseases, as you'll see, if they're going to produce casualties, they're going to produce neuromuscular casualties. And then the E stands for exposure. That's where the surgeons get to cut off all your clothes so they can do a more thorough exam. And that's where we consider the need for decontamination. So that brings us to the fourth step: thou shalt decontaminate as appropriate. The first question is decontamination even necessary? Is this B'nai B'rith, bleach them down in the streets kind of stuff even necessary? Well, I would obviously not, or we wouldn't be talking about it. But a lot of the trouble I think we've gotten ourselves in comes because we've misappropriated military doctrine, and in fact the military is guilty of misappropriating its own doctrine. So from 1915, when poison gas was first used on the battlefields of World War I, until 1998, when the first biological defense doctrine was promulgated, we had this chemical doctrine, and at the end of every chemical training manual and stuff, it would be basically a paragraph that would say, you know, whatever you did for chemical, do the same thing for biological. So from 1915 until 1998, this was kind of our doctrine. And the doctrine said that for material that was contaminated with chemical or biological agents, you would decontaminate it with 5% hypochlorite. That's full-strength Clorox right out of the bottle. So in the military, you know, Private Snuffy is told, you know, if you drop your M16 or you drive your tank through a puddle of nerve agent, that you should bleach it down, and that's fine. I have no problem with that. They very early on realized, though, that bleach was macerating on the skin, wasn't very healthy, and it ran the risk of causing skin breakdown, which would allow more agent in. And so somebody has a total swag, just kind of made this up, no data behind it, but said, well, let's just dilute it 1 to 10. And so for decades, that's what we did. We used a 1 to 10 solution of bleach, and that was kind of supposed to be the decon solution for human skin. We now know that that's macerating even. That runs the risk of allowing more agents in. And furthermore, soap and water works just as well. So and think about what you do in conventional medicine. We deal with some pretty infectious, pretty contagious, pretty dangerous things in conventional medicine all the time, like pulmonary tuberculosis. So if a tuberculosis patient coughed on you, you know, what would you do? You go to they coughed on your arm. Hopefully you're wearing an N95 mask, so they're not coughing in your face, hopefully. But let's say they cough on your arm. What do? You go to the sink and you're going to wash. What are you going to wash with? Soap and water. So if it works for conventional things, it works for these agents as well. Now, we are guilty of kind of combining chemical and biological decontamination a lot of times when we talk about it. And I think there's times when that's okay. Again, if I've got my 18-year-old infantryman and he's bopping along the battlefield and a yellow drop of oily liquid drops off a tree and lands on his arm, to be honest, I don't want him sitting there saying, well, should I decontaminate or should I disinfect? I just want to wipe stuff off. But I think we in the medical world, public health world, preparedness world need to be a little more sophisticated than that. So when we talk about biological decontamination, we're really not talking decontamination at all. Rather, the proper terminology is sterilization versus disinfection. So sterilization is the removal of every last vestige of microbial life. So is it necessary to sterilize anything after a biological attack? Well, think about it. I told you that there's Clostridium botulinum in the soil everywhere. You can dig up a few scoops full of dirt and you can culture yourself that. So you get dirt under your fingernails. A lot of times there's botulism spores in there. And you pick your teeth, you're eating botulism. And yet you don't get botulism from that. So clearly it's not always necessary to sterilize everything. So if a scalpel's going into my appendix, I would like it sterilized. But I would like it sterilized anyway. What we're rather talking about in the biological business is disinfection. And there's a lot of levels of disinfection. You can read about them in your hospital control, infection control manual. But to summarize, I would say that for personnel, decontamination is rarely necessary at all. And it's certainly less relevant than it would be after a chemical attack. And why is it rarely necessary at all? Because remember, biological agents have an important characteristic that chemical conventional nuclear agents don't have. That's an incubation period. That incubation period is usually several days in duration. So if the patient's presenting to you and they're sick, their exposure occurred several days ago. So if they have any standards of personal hygiene at all, they've hopefully taken several showers, they've changed clothes several times, there ain't nothing left to decon. But if you happen to get that rare patient who the crop duster flew overhead and they showed up in your ER covered with white powder, then that's a little bit different story. But that's unlikely to happen. But the bottom line is soap and water would work for that case, and use common sense. When we're talking about material, I would argue decon is also unnecessary. and in many cases, and certainly less relevant than it would be after a chemical attack for all of the same reasons. Because by the time you know it, the attack was often several days ago, the stuff's all been degraded. The military doctrine is 5% bleach, and that will work. And if it makes you happy to take your non-porous personal effects, your jewelry, your eyeglasses, and dip them in bleach, that will work. Because even 0.1% bleach kills anthrax spores, and even a lot less than that kills everything else. So it's probably overkill, but it probably won't do any harm. All right, so you have your index of suspicion, take a step to excel, save the patient's life, decon him if necessary. Now it's time to turn your attention back to the patient, this time with the eye towards making a diagnosis. And we call this the secondary survey. So how do we do that? Well, I'm not going to sit up here and tell you, how to take a history and do a physical. Those of you who are clinical probably know it better than I do, and those of you who are not clinical don't care because you're not going to have to do it. But so the first thing you want to do, though, is take a history. And obviously, in a mass casualty setting, we don't have time to do a 2-hour-long medical student history where we talk about your third cousin and whether they had type 1 or type 2 diabetes and stuff like that and what your dog died of. So we're going to limit it to an ample history, and I'll just leave it at that. And the next thing we do is we do a physical exam. And again, I'm not going to sit up here and tell you how to do a physical exam, but suffice it to say, in a mass casualty incident where all hell's breaking loose, we're going to limit that to the most important information. The most important information lies in the respiratory and neuromuscular systems, and to a lesser extent some other things, and we'll talk about why in a minute. And then after we take a history and do a physical, we may obtain some lab studies. And I'm not going to say much more about this because what you do laboratory-wise is going to depend a lot on where you are. In the military, we talk about 4 echelons or 4 levels of care, and the same thing would apply in the civilian world. So in the military, for example, level 4 would be Tripler Army Medical Center. And if you happen to be at Tripler Army Medical Center during an attack on Hawaii, then you probably have PhD microbiologists, and you have infectious disease consultants, and you have PCR primers, and you may be able to obtain some sophisticated laboratory studies and get some answers back in a few hours. On the other hand, if you're in a little clinic on Molokai and the terrorist attack occurs and casualties are presenting to you, it's probably going to take you quite a while to get those specimens to wherever they need to get to. So in the military, again, we have everything from major medical centers to a medic with an aid bag in a rubber boat with 5 guys under cover of darkness who are getting shot at. And chances are that medic in that rubber boat probably didn't pack PCR primers in his aid bag. So again, what we do laboratory-wise depends a lot on where we are, and that's all I'm going to say about it. So that brings us to the next step of rendering prompt treatment. But wait a minute, how do you render prompt treatment if you don't have a definitive diagnosis? So I just told you that to make a diagnosis, we're going to take a history, we're going to do a physical, we're going to get some lab studies. But I kind of left it at that. So how do you render prompt treatment? Well, if you can make a definitive diagnosis very quickly, then the rest is easy. Then there's plenty of expert. If you're at Tripler and you've got PhD microbiologists and you've got PCR primers and you've got culture material, they're probably going to be able to give you an answer in 30 minutes to 2 hours as to what you're dealing with. And then you're going to look up in a textbook, or you're going to ask your consultant, well, what's the best drug to treat this with, and blah, blah, blah. But what if you're with those 5 guys in a rubber boat under cover of darkness and you're getting shot at and you don't have any more than a few Band-Aids? Or what if you're at that little clinic on Molokai and you don't have a way to get your specimen to the Hawaii State Health Department in quick order? What do you do? How do you render prompt treatment in those circumstances? Well, I would argue that even in the most austere of conditions, even the most junior of you right out of training, if you can't do anything else, at least you ought to be able to do this. You ought to be able to decide, are my casualties pulmonary casualties or are they neuromuscular casualties? And you ought to be able to decide, did they come in immediately? In other words, did the weapon go off and everybody fell down and they're tightly clustered in time and space, in which case they're almost certainly chemical casualties, or do they come in delayed fashion? So if you can do nothing more than that, anybody ought to be able to do that. Are they pulmonary, or are they neuromuscular, are they delayed, or are they immediate? If you can only do that, you can create this 2x2 table in your mind, and you can put virtually every one of these casualties into one block of the 2x2 table. But who cares? So what if I can do that? Because there's still several agents in each category, right? So how does that help me? Well, think about it for a moment. Let's say you were the most brilliant public health official ever to come out of public health training. And you're able to just lay your hands on the patient and say, I think this patient has phosgene intoxication. So what are you going to do for him now? Supportive care, right? There's no antidote for phosgene and no antidotes necessary. So we're going to, if they're having trouble breathing, we'll give them oxygen. If they're having trouble drinking, we'll give them IV fluids. But we can do that whether we know they have phosgene or not. So if I throw out of this paradigm everything for which supportive care is adequate or supportive care is all that's available, then the list gets a lot shorter. Now there's only one in each category except for the delayed pulmonary category. So let's say, again, you're the most brilliant public health official, preparedness official ever to come out of training, and you lay your hands on the patient and say, I think this patient has anthrax. What are you going to do for him now? Doxycycline or ciprofloxacin, right? What if they have plague? Doxycycline or ciprofloxacin. What if they have tularemia? Doxycycline or ciprofloxacin. Now, Colonel Cieslak is a member of the Infectious Disease Society of America, and you know how ID doctors are. So if they heard that I was up here saying, don't bother thinking about the patient, just put them all on doxycycline, so I would get kicked out of the IDSA. So I will deny that if anyone. And in fact, that's not what I would do if I had the wherewithal and the ability to make a definitive diagnosis. I would want to do that. But on the other hand, if I was with 5 guys in a rubber boat under cover of darkness and my guys are dying of delayed pulmonary symptomatology, you better believe they're getting ciprofloxacin or doxycycline. So I can't make it any easier than that. If you have immediate pulmonary casualties, they get a cyanide antidote kit. If you have immediate neuromuscular casualties, they get a nerve agent antidote kit, which is atropine and pralidoxime. If you have delayed pulmonary casualties, they're getting doxycycline. And if you have delayed neuromuscular casualties, they're getting botulism antitoxin, which isn't available in your rubber boat anyway. So they're going to get probably not available on Molokai either. So they're going to get evacuated as quickly as possible to the next echelon of care. All right, so now you've made that diagnosis, whether it's definitive or syndromic, and you've prescribed that prompt therapy. Next thing you need to do is make sure that the rest of your patients don't contract what your initial patient had. In other words, you're going to practice good infection control. And you all know standard precautions. Who should you be approaching using standard precautions? Everybody, right? So standard precautions are just common sense stuff. So as an ID doc, we recommend that if you are doing a rectal exam, you wear gloves. So kind of common sense sort of stuff. And for most patients, that suffices. But every once in a while, we want to do something a little bit more. And so transmission-based precautions, there are 3 categories of those. And the most stringent of those is airborne precautions. So these are the diseases in conventional. Traditionally, there have only been 3 diseases where we would ever use airborne precautions. Those are measles, chickenpox, and pulmonary tuberculosis. And now with SARS and MERS, I think most experts are coming around to thinking, we probably ought to use them for that as well. So if there was a bioterrorism disease I told you required airborne precautions, think about what you would do for a pulmonary TB patient in your hospital. It's the same thing you would do for that bioterrorism disease. Same thing with droplet precautions. A bunch of diseases in conventional medicine that require them. If there was a bioterrorism disease that I told you needed droplet precautions, think about what you would do for a hospitalized patient with influenza. And same thing with contact precautions. If there was a disease I told you needed contact precautions, think about what you would do if you hospitalized a MRSA patient. And fortunately for us, there's one of these in each category. So smallpox requires airborne precautions. Plague requires droplet precautions. Some of the viral hemorrhagic fevers like Ebola require contact, and just to be safe, we impose other precautions as well. But for everything else, like anthrax and tularemia and brucellosis and Q fever and staph enterotoxin B and botulism and stuff, standard precautions suffice. All right, so the next thing you want to do is alert the proper authorities. And there are certainly rules about reporting. Certain diseases are reportable by law. This is just a 5-year period of what actually got reported to the Centers for Disease Control. And I show you this just to make a point, but the real point is that this is much to do about nothing. Because if you suspect the disease is intentional, then you ought to be reporting it regardless of whether it's officially on the list of reportable diseases. So eventually a machine's going to do that for you. So after you've done that, now it's time to go where the money really is. Because remember, we said the guy with the widened mediastinum is the canary, right? And of course we're going to try to save his life. But more importantly, we're going to learn from him. We're going to say, this got to be anthrax. And if he got exposed, a lot of other people probably got exposed. And we need to get to those people, and we need to get to them quickly. So we need, and obviously, if you're a clinician like me, you can't. I don't have the training to do that, and I don't have the time if I'm in the middle of a mass casualty situation. So a public health official is going to do this on a formal level. They're going to generate a 30-page questionnaire, and they're going to distribute it out to every citizen who might have been affected. It's going to ask where you ate every meal for the last 2 weeks, and what you think you ate, and whether you were at the Punch Bowl, or whether you were at the Aloha Stadium, and when you went to, you know, the Hilton Hawaiian Village, and whether you were at this luau, and et cetera, et cetera, et cetera. So somebody's got to do that on a formal level, but clearly in the setting of a mass casualty incident, we don't always have the time. I would argue, though, that even the most junior of us clinicians do this on an informal level without even thinking about it. So we make an observation. I think Joe Citizen has anthrax. We count cases. How many other cases of anthrax are there? We relate cases to the population. Does anthrax occur normally in Honolulu? We make comparisons. Nope, I don't think it does. We develop a hypothesis. I bet Joe Citizen got slimed. So again, we do this on an informal level all the time, but somebody needs to do it on a formal level, and that somebody is the public health authority. So this is really just a plea that, you know, the real money is in the public health side of this problem, and you need to get your public health people involved. So just to summarize, I know I'm 2 minutes over, and we're probably not going to have time for questions right after this. So, but I will be here in the question and answer session at the end of the day. So if you do have, and I'll be around all day. So if you have questions, you can corner me in the side, or we can handle them formally at the end of the day. But just to recap, so World War III's breaking out. You got your index of suspicion. You've taken steps to protect yourself. Those steps might involve wearing a mask. They might involve taking pre-exposure antibiotics. They might involve getting immunized. They might involve some combination. They might involve none of the above. But at least you've given it some thought. Then it's time to start seeing patients. The goal in that initial survey is not to make a brilliant diagnosis, but rather to save the patient's life. You're going to do that by quick attention to the ABCs. Then you're going to consider whether decon is necessary. Most of the time it won't be, but at least you've thought about it. Then you're going to make at least a syndromic diagnosis, if not a definitive diagnosis. You're going to prescribe empiric therapy based on that syndromic diagnosis. You're going to institute the proper infection control measures. You're going to notify the proper authorities. You're going to get the epidemiologic investigation going. And then you're done, right? It's Miller time. You've done your job. And I'm confident any one of you could spit back out at me right now all these 10 steps. But can you do it 2 years from now when this is just a distant, blurry memory? So you are now the experts for the state of Hawaii. You truly are. And it's your job to spread the gospel and to continue to know the gospel and study this. So for those of you with absolutely no social life whatsoever, I used to host a television show on the Public Health Training Network, and so we have a 12-hour gift-boxed set of videotapes. So, unfortunately, they're VHS tapes. You have to find a VHS player. But so, if you have no social life at all, we'll send you a set of those. There's also plenty of other training aids and books. So, if you want any of these, we're always happy to send a copy for free to anyone who wants them. If you want 500 of them for the whole health department, we'll charge you a nominal printing fee. But I'm happy to get you those. You can either email me, or you can just go to the webmaster at USAMRIID and tell him the big ugly old colonel said I could have a free book, and he will know exactly who you're talking about. So let's say World War III breaks out, the terrorists at our doorstep. You're prepared with your VHS tapes, but all they have is DVD technology. So now what do you do? Well, now you call me. So you can call me at my partners, since I'm not there physically, at 1-888-USARID. I would caution you that this is a 1-888 number, not a 1-800 number. It's a true story now. And that will get you the bio-incident line at the hot zone at Fort Detrick. And again, I would caution you, it's not a 1-800 number, because if you call 1-800-USARID, you will get hot live talk. You'll get the hotter zone. A true story. Not that we check it out. But and I know this because my boss, the former USAMRIID commander, he was very proud of this toll-free line. So when he got it, he invited his boss, the two-star general, over, and he's going to show off the toll-free number and a lot of other things. So you know how two-star generals are. They never travel alone. So he brings his whole entourage. They sit around the table, the conference table. He puts on the speakerphone. He dials up inadvertently 1-800-USER it. He gets hot live talk. And they talk to him for free for about 3 minutes. I'm surprised he let it roll with the general sitting there. And then they referred him to the 1-900-GET-ME-HOT number, the $3.90. So anyway, if you need to call us, it's a 188 number. And with that, I apologize for going over. But again, I'll be around all day. We can ask questions. Is that okay? Okay. Yep.